So before we proceed with any procedure, always you should be familiar with the device. So orbital atherectomy, a new device, new entrant into the market. So this is very useful actually. Compared to Rota, easy to learn, and advantages are it has a forward cutting and backward cutting, and eccentrically mounted. Only single device you can increasing the speed of the crown. You can get better luminal area. That's very important. Right? Suppose the vessel size is 4 mm, you can go with a 1,20,000. If it is smaller, like a 3.5, you can go with 80,000. So the wide is also very important. It's more trackable. That is the advantage of the orbital atherectomy. Only thing is you have to move it very slowly. That is 1 mm per second while moving forward and backward, because it moves along the periphery of the orbital motion. So central lumen of the blood vessel is available for purging. So continuous flow is maintained so that the debris clearance is much better. The debris what we generate is 2 microns versus 7 to 8 microns with a Rota. So Rota, it requires definitely the learning curve is more compared to orbital atherectomy. But it's a wonderful device, particularly when patient is having a balloon uncrossable, very tight, very critical lesions, ostial lesions, distal lesions, less than 2.5 mm, you can nicely use it. But only disadvantage, if you are, suppose the tapered vessel is there, proximally it's a big vessel is there, distally the lumen is small, particularly diffusely calcified lesion, you may have to upsize the Rota. So if you are going with more than 1.75, if you are using 6 French, you may have to upsize the guide catheter. These are the disadvantages. If you don't use it properly, if you don't handle it properly, there is a chance of complications like a stuck burr, burr stall, and burr. These are less with orbital. Why? Because even if crosses the tightest lesion, you can do the backward cutting. That is the advantage with it. Because the debris generated is very large compared to orbital. The slow flow, no flow less, and at the same time the heat generation is more, thrombosis formation is more likely. So I will narrate with some cases. You can see the LAD very tightly stenosed. It's a calcified lesion. So the always assess with the imaging, whether use IVUS or OCT, you see the calcium expansion index and where exactly the severe calcium is there, target that lesion to be more precise and more cost effective. That is very important. So always when you do the Rota or orbital, aim for achieving the fractures. You can see the very thick calcium, more than 1 mm in certain areas. You can see the very thick calcium with the proximal LAD. So that with high calcium expansion index. So after orbital atherectomy, you can see very clearly the calcium fractures and areas of dissection you can see. When you see the calcium fractures, when you see the gain in luminal area, that means you have adequately ablated. Otherwise, you have to upsize, or you can additional adjunct device like using the IVL or some other device you can, like an open NCR, additional cutting device, you have to use it. So this is after orbital, the advantage of this like a single bar, single crown, you can increase the ablation area by increasing the speed, and the learning curve is very fast, and the complication rate is very low compared to the Rota ablation. So this is after stenting. You can see the always document that stent expanded very well, luminal area is good. So your edge rejection is not there, and there is no geographical miss. That is very important. So this is the final angio. See, very good luminal areas, and absolutely very good plaque modification with orbital atherectomy. You can see that there is slow flow, calcified lesion, and patient present with anterval MI and LSEC thrombus, late arrival, almost 1 week duration. Then we treated with anticoagulant subsequently. You can see the proximal LAD we ablated with orbital atherectomy. When you manage such case, always prepare mentally yourself to have a, you are going to face the slow flow, no flow. That time you keep all inotropes and all the cocktail, whatever you wanted to inject into the coronary system. So this is the assessment after stenting, after Rota ablation, after orbital atherectomy. There is a nice luminal gain. So stent expansion is very good, and based upon that you can, so always take the total run. You see distally, despite using orbital, despite using the multiple devices, there is under expansion. Many times angiogram may not show. That's the reason you see area distal edge is almost 2.8. The stent area, the expansion is there 70%. Then we have upside, and again it was post dilated. Now we have proved that it expanded well with the OCT. So always the expansion is very, very important. So as have you got the max criteria fulfilled or not? Otherwise, the MACE rate is going to happen. This is a right corner. You can see very, very severely calcified, concentric, superficial, and deep calcium. You can see here, right corner is having ostial lesion, top to bottom disease from proximal to distal, and ostial right coronary you can ablate. Left main coronary also you can do with orbital therapy. Only thing is avoid very tight stenotic lesions. See, this is after orbital atherectomy. Proximally we did 1,20,000. Most of the time the studies recommend that avoid more than 80,000, but only if straight vessel. If it is a main left main vessel, you can go ahead with 1,20,000. So after orbital atherectomy, again evidence of fractures and dissections. You can see nice fractures, and after that the post again prepared with angioscalp. Most of the time nowadays we use angioscalp for cutting balloon and or high pressure NCs, and prepare the bed well and expand it, and even PDA was stented, and this is the stent expansion, OCT views, 3D imaging, everything. So it's a very nice to see that stent is expanded very well, opposed very well, and without any edge dissections, these geographical miss. These are all important to provide the better long-term results. So otherwise what happens, patient, you can see the classic ostial left main disease, isolated left main lesion. Sometimes we may think it's a lipid block, fibrous block, but always evaluate the OCT. I was showed a very tight eccentric calcific lesion, eccentric calcific lesion involving the left main ostium. So what we did, then orbital atherectomy was taken, and we pushed orbital atherectomy, reverse cutting, again forward cutting, entire left main ostium was ablated with almost 1,20,000 revolutions were used. And when you use Rota, always see that the alignment is proper. Suppose Rota floppy you are using, you go with extra support wire to align with the otherwise what happen, it may dissect. Otherwise sometimes if it is not allowing, you can take the angioscalp and dilate the ostium and then use the Rota. That is a very useful technique. And this is the another case where you can see very classic case. The patient underwent stenting of the LAD and LCX, but left main distal disease or LCX ostium disease and proximal diffuse disease. If you see the IVS of the LAD and LCX, diffuse disease of the LAD as well as calcium, neoarthrosis, calcification. Then we did the orbital atherectomy. Always we assess the different areas of the each segment you study well, where there is a tightest lesion, where the expansion induction is high, there you concentrate more. And orbital atherectomy, entire LAD was done and L6 was done. You can see the movement of the, but you have to be very, very slow when you use the orbital atherectomy. 1 mm per second during forward motion and backward motion. That is very important while doing. And I shows areas of calcific nodules which are less amenable to the, you can see the areas of neoarthrosis in the left circumflex, and this is the again angioscalp preparation of the LCX as well as the LAD. Again we use the classic DK crush, all the steps like LAD was stented and stent extending from the LCX and crushed with all classical steps, first kissing balloon, and this is the final angiography result. So this case was attempted outside. You see the very calcified vessel, very tortuous is there. What we thought, let us try with the orbital. But in such case, never try with the orbital. It was uncrossable lesion. So you see the only proximal segment, we were repeatedly trying, but never force. If you force it, it can lead to spiral dissection, no flow, slow flow, and patient can suddenly crash. You have to be very careful while dealing such cases. So then what we did, we took 1.25 burr and ablated the entire LAD, and subsequently we took the, again repeated the orbital atherectomy. You can see the orbital atherectomy. Now it's moving very well, and distally there is a calcium nodule, and you see the entire LAD was both Rota plus orbital atherectomy was done. You see the final angiography. Nicely flowing LAD, LCX, and beautifully ablated. So effective modification of the block is very important to achieve wonderful result. You can see the LCX calcific nodule. You can see the LCX calcific nodule when severely calcified. It's very difficult to cross the lesion. So sometimes even with the difficulty, even with the guideline also difficult to cross. But when there is very tight lesion is there, calcific lesion, definitely the Rota is the best choice. But here we tried with orbital atherectomy. So always calcium assessment. So when you choose the device for calcium nodule, is it very tight and occupying the entire lumen? Then Rota works very well. Wire bias are there, but Rota works well. Suppose if it is a large lumen with eccentric nodule, only you have to use the orbital atherectomy. So otherwise, it may not ablate very properly. Otherwise, take the help of the wire and guide wire bias. Then this is the orbital atherectomy. Then finally, you can see very nice fractures with orbital atherectomy and shaved calcium nodule of the left circumflex ostium and left main. So there is a significant gain in the left main area. So then it was stented, kissing was done. So you can see the final view. Very well expanded stents. Left main is very good, and left main area we got 19 square mm. So sometimes we come across a very diffuse long lesion, severely calcified, uncrossable lesions. You can see the Rota was done. So Rota, if you see the OCT, there is a calcium nodule. When calcium nodule away from the lumen, sometimes it may not ablate well. That time you have to use the high pressure NCR. In such case, if you use the orbital, it can ablate the calcium nodule very well. So this is the final angio. That time we used, this was done about 9 years back. Even today it's absolutely fine with a long-term follow-up. So that is the reason adequate preparation of the bed makes a difference. So as of now, I have done my personal experience, 2014 Rotas and IVL 128 patient, orbital atherectomy 26 patient. To conclude, the balloon uncrossable lesions, Rota is the first choice. No matter what, you can't travel unless it paves the path. So orbital is a cost effective. Why? Because one device can work for both. Suppose if the left main is bigger like a 4 and LAD distal is middle is about 2.5. One device is enough. You can use the 80,000 distally, and proximally you can go with a 120,000. And superficial, it can act on superficial, deep, eccentric calcium nodule. Range is wide, and large lumen area with eccentric nodules, it acts very well. And severe superficial cancer, any critical lesion, any tight lesion, uncrossable lesion, Rota is the first choice. But if very critical uncrossable lesion, if you use the orbital atherectomy, sometimes it can move around the periphery. It can cause the spiral dissection that can lead to the problem. A majority of the patients can be performed, all the procedures can be performed to the 6 French transradial, because orbital atherectomy requires 6 French compatible, whereas Rota requires, if you want to use the bigger bar, you have to go. Though you can use the slender sheath, we can do, but the tortuous anatomy there, in such cases like a bigger bar 2 mm, you have to go with a much more bigger catheter, which is not possible. It is not as simple as balloon basin. It is an art. One has to learn. You have to be very familiar with how to use. Most of the problems are because of the bad usage because of poor technique and poor operator, not because of the device. It is safe as long as you handle it with care. Thank you, one and all, paying the attention. Thank you, one and all.